Well, thank you very much. We're going to go right into our awards session. I have the privilege of introducing the Atlas Award. The Atlas Award celebrates the career and impact of physicians who have distinguished themselves as scholars and leaders in their respective vascular fields. They've committed their careers to advancing the care of patients with vascular disorders and have taught countless numbers of physicians techniques to expand care across the United States and the world. Previous Atlas Award winners include last year's Dr. Michael Dake, who gave an outstanding lecture as well as during the Atlas lecture portion. These are the 14 other Atlas Award winners who read like a who's who in medicine, people that have really been innovative and taught us much. This year I'd like to introduce Dr. Peter Schneider as the Atlas Award recipient. Peter is currently Professor of Surgery at the Division of Vascular and Endovascular Surgery at the University of California, San Francisco, but prior to that, Peter practiced for 30 years and was a founding member of the Division of Vascular Surgery at Kaiser Permanente in Hawaii until 2018. If you look at his accomplishments, Peter Schneider is a powerhouse. Peter completed his undergraduate schooling at the University of California, San Diego. He then went on to Johns Hopkins University and did his residency and fellowship at the University of California, San Francisco. He has 150 publications, 46 book chapters, 7 authorships, including the trainee Bible that we call the Endovascular Skills book, that I think everyone in this room has either used or made sure that their trainees have a copy of this. He's been national PIs of numerous trials to include the IMPACT SFA trial, the Scaffold trial, the Roadster 2 trial. He's been visiting professor at over 30 institutions and invited faculty to over 100 conferences around the world. But where did Peter start out from? If you look at Peter, there's his high school picture. Peter always had great hair, and I think that's one thing that you can never discount as mine becomes thinner and thinner. And if you look at Peter, the middle picture, that's his Johns Hopkins ID. Looks a little, that's the first time I've ever seen Peter not looking cool and collected. And then a little later, if you look over to the right, he's got the mustache happening now, seems a little more confident, hair's a little shorter. And that's because I think Peter met the love of his life, Vicki, who was a fellow medical student at Johns Hopkins. Peter and Vicki were married, and the honeymoon, of course, is going to be somewhere on the beach because Peter was a surfer. And, I always said Peter Schneider is probably the coolest guy in the room. And if you look at this picture, why can't we all be like this? But one thing that Peter has taught me is things about the family. And this is very personal to me. I am a vascular surgeon today because of Peter Schneider and what he's meant to me. I was a young resident that rotated with Peter Schneider, and one of the things Peter always emphasized is his family. Peter has a beautiful family of Colin, Beecher, Keeley, and Brenna. And you could see he was very young when he had his children. And his wife was a physician as well. So you talk about work-life balance, they had to work really hard to make this work, and they have a fantastic, beautiful family. I've met all of the children. They're just great people like Peter and Vicki are. And you can see this is how Peter did it. He would bring Beecher and Keeley to the operating room with him and make them be assistants. And I think that's how Peter made all of this happen for him. But as a surgeon, Peter's really a true surgeon. Be it endovascular skills or open skills, complex, he is I think, what we all aim to be. When vascular surgery was going through some changes and really needed to embrace the endovascular paradigm, he was the one that really led the way for our entire specialty. Peter would be doing complex cases, open cases, as well as endovascular cases. And the one thing about Peter Schneider, if you know Peter Schneider, you feel like he's your best friend. As you can see, when he looks at you, he always has something to tell you or ask about somebody in your family. He's that person who I think embraces everything that we want to be. And you can see him in his days with his partners Nick Nelkin and Mike Capps at Kaiser and the legends that they were there. Peter's traveled around the world, and you can see prior Atlas Award winners with him and likely future Atlas Award winners with him as well. But his travels have taken him everywhere. And one thing about Peter is that when you see him, he'll be like, I just got back from Paris this morning, but he doesn't look like he's jet lagged. And I don't know how he does it. Maybe it's all the surfing, I'm not sure. But there's something special about this person, and I've known him for a long time. Peter now has 4 great grandchildren, Isabel and Troy and Shiloh and June. And I think that he and Vicky are enjoying this part of life where he gets to spend time with his grandkids and these moments in life where the entire family is together. I will just say that nobody embraces innovation, work-life balance better than Peter Schneider. And it's my true honor to recognize Peter as this year's Atlas Award winner. You're gonna have to carry this throughout the whole talk.
Thank you, Niten. Put it up here. Oh my goodness, thank you so much. Thanks to Niten, who's really one of the best people I've worked with. I'd like to thank also VIVA. It's been a pleasure to be part of this organization for these years, and I do think that it's got a bright future. Also that, as we move forward, we're going to talk a little bit, I'm going to talk a little bit about innovation here in these next few minutes. But what I really wanted to talk about, this concept of being passionate about vascular care, how to grow in an era of change and challenge, really talking about things that we know, that we think about, that we talk to each other maybe quietly about, but we don't really talk about it in a forum, in a format like this. So we don't have all the answers in 2023, but we've made incredible progress in our field over the past 20 years. I would like to declare the vascular field a success. And that it wasn't really quite clear that it was going to be a success in the era when I got interested in it in the mid-1980s when I was a House officer. And in order to really look at this, I think we need to evaluate where we've been and consider where we're going and use that as a context for how we might remain passionate despite all the challenges that we are going to face. So defining the vascular mindset, really, who are we, is the kind of the first issue at hand. And I would say this is not just a doctor-to-doctor kind of thing. If you think about what makes us successful, it involves nurses, PAs, NPs. It involves an entire practice infrastructure, the endo suite, the angio suite, the cath lab, all the people that make stuff happen in our immediate environment. But then there's this whole structure around us. I mean, I've been running into the same industry reps for 30 years. They might have changed companies, but they're there, and sometimes they've driven hours, hundreds of miles, or they've flown thousands of miles to make sure that my case is gonna happen the way I want it to happen with the stuff I need and when I need it. There's a whole innovation infrastructure out there of people who are interested and knowledgeable about vascular in a way that frontline docs are interested and knowledgeable about vascular. So who are we? Well, I would say we take on seemingly impossible clinical situations, in general take more responsibility and advocate more strongly for patients than most any other doctors or specialties that I know. Vascular is humbling. You can do everything right and sometimes still have a bad outcome. We also work hard, very often first in the hospital, last out to go home. We don't go till the work is done. You have a really sick patient. It can take up days of your time and concentration right in a row. We have also colleagues, hospital administrators and payers and others who are near us and interested in what we're doing, but actually have no idea what we do. We're sort of the original, or let's say the residual Stoics, or practice Stoicism in that sense on a regular basis. Also, this idea that it's not the journey, it's the destination. I picked this quote from Arthur Ashe, who you probably, a lot of you will remember that Arthur Ashe was the first major African-American tennis star in the United States. He died young of AIDS related to a transfusion. But he said success is a journey, not a destination. The doing is often more important than the outcome. And so let's define our journey first. So I'm just going to define vascular for us. This is my definition. You may add or subtract from this, but I would say it's a unique combination of multifaceted, multi-organ system care in patients with little margin for error. It's an opportunity to make long-term relationships and to make a difference in the lives of our patients. The goals are practical, dilemmas are intellectually stimulating, the procedures are anatomically based and aesthetically pleasing and technically challenging, and there are still numerous opportunities for innovation. The stakes are high and the outcomes are real and cannot be explained away. And we take them personally. The patients are often the most vulnerable from a medical and socioeconomic standpoint and are, for the most part, realistic about their respective conditions and appreciative of our efforts to help them. So vascular care really gives us an opportunity to return to our roots as caregivers. It's patient-focused. We're intending to relieve or prevent suffering. We have to understand anatomy, boost our technical skills. We have to be deliberate about patient selection to get the best results. And we are very often caring for those who need it most. And we have made massive progress in the past 2 to 3 decades. Our support system and practice infrastructure, every single one of these has advanced from screening to vascular lab to ultrasound every day to advanced imaging, et cetera, et cetera. Here are just some of the advances in medical management with DOACs and antiplatelet agents. There's a Voyager trial with a significant reduction in MACE with aspirin and rivaroxaban. There's evolocumab now with a significant reduction in MALE and MACE. And these are just a couple of the ones that rise to the top. We also have now advanced imaging as a routine. It just wasn't that long ago that Hounsfield was looking at the first CT scan of the brain, just really 3 decades ago. And I think at this point now, this kind of vascular imaging, which is helping us to understand the patient before we take them and make a plan or set up an algorithm. The incorporation of ultrasound into daily practices happened gradually, but I think this is the one maneuver that has dramatically decreased the everyday access-related and other strategic errors that we had made in the past on a regular basis, insisting, of course, that we knew the anatomy, but with ultrasound now we know it so much better. Other advances in the tools and devices, wires, catheters, sheaths, recanalization, crossing, vessel prep, debulking, thrombectomy, filters, there's been an explosion in all of these, and we've benefited from these. And we've sort of taken these in stride on a day-by-day basis, but when you look at how many things have come just in the past 2 to 3 decades and have made our field so much more sophisticated and so much more up-to-date and something that we can present to the patients, not as necessarily as a finished whole, but that we can practice state-of-the-art work today in a way that we couldn't in the past. And in fact, every vascular bed and every condition we treat has advanced in the last 2 to 3 decades. Not all are finished products, but so many of these things, when you look even at carotid intervention now, is undergoing a whole new evolution. Lower extremity, we just saw an amazing CLTI case. Pulmonary embolectomy now has become a routine in many, many hospitals. And now we've noticed disparities in vascular patients and things that we need to work proactively to correct. And there's a whole session on that tomorrow. And I just wanted to acknowledge these. Niten mentioned the previous Atlas recipients. I feel I'm not really in this category. Actually, when you look at these people, these are my mentors. If not direct mentors, they were role models. Every single one of these people contributed to that advance that's happened over the last 2 to 3 decades. And now we have things taking place on a routine basis that really just didn't even exist a few years ago, whether it's, as I said, pulmonary embolectomy or reverse flow for carotid stenting, pedal angioplasty, the focus on vessel prep, focal dissection repair, DVA, IVL, EVAR for rupture, percutaneous fem-pop, and now DRS, hopefully coming soon. So there are challenges in the vascular field. It's a small field, which means we don't always get the attention we feel we deserve. Don't always get the R&D we were hoping for. It's a multi-organ field, which means we need to keep up. It's the highway to every organ, and so we need to keep up on a lot of different pathophysiologic developments. We need to understand how to integrate outpatient care. We've worked hard to make these procedures minimally invasive, and now so many are outpatient, performed in an outpatient basis. However, we need to integrate that care into the whole system. It's multidisciplinary, which can make it challenging because we're not always wearing the same stripes or speaking the same language. The demographics, potentially an avalanche of work to do. And it's also in the underprivileged. These are patients that very often don't have a voice, especially if you think of the CLTI population. But each one of these is a potential opportunity. With a small field comes that collegiality. With that multi-organ approach, it absolutely never gets boring. That outpatient need for outpatient integration, yes, we've had some challenges. It's been on unfortunately, the front of the newspapers. But ultimately, this is going to be better for patients. We've all worked hard to make these procedures less invasive. It is multidisciplinary, and that allows us to learn from each other. And the demographics are horrifying when you look at the potential avalanche of cases, but we will always be needed, and we will always need to develop more. And we take care of a lot of underprivileged people, but I think it also gives us a greater purpose to what we're doing. So if you look at just that life expectancy issue, it's climbed steadily over this past many decades. Took a little dip then during the COVID time frame, but at birth now, life expectancy 76.4 across the whole population. It reached age 65, it's 18.5 years. But if you look further back, you'll see that we're at a specific place in time in history in that millennia have gone by without the kind of life expectancy that we expect today. And in fact, 2/3 of the people in world history who've reached the age of 65, they are alive right now. And that tells us something about the demographics we're facing. So how to integrate the opportunity for outpatient care safely and with highest quality. And unfortunately, here are some ProPublica articles, the Wild West of vascular, the arterial motives, the big business of clogged arteries, this Wall Street Journal article, and then of course culminating in the New York Times article that came out this past July that was sort of a crystallizing moment and generated so much discussion in our field. I do think that the patients need a simpler way, a less invasive way, and I do think outpatient care is really a big part of our future, but it has to be done safely and with the highest quality. And there are lots of articles like this showing that it can be done safely and with the highest quality. So we clearly have work to do, and we don't want to brush things under the rug, but I think that this is a real opportunity for us to do it right. We've also shown we can work together. The story of paclitaxel across industries, specialties, countries, regulatory bodies, and this is the Lancet last week published this latest meta-analysis with an additional 3,000 patient years of follow-up now with 2,600 plus randomized patients to 5 years or more after paclitaxel treatment showing no signal. But when we take a step back and look, okay, well, I'm kind of summarizing where we've been and where we are, but what's going to happen next? So I look at it this way. I think there have been basically 3 developmental phases of vascular care. The first, how to get sick patients safely through major open surgeries, which roughly took place between 1970 and 2000. The next was how to manage complex disease with minimally invasive approach, and that really took place or has taken place from 1990 to 2020. Of course, there will continue to be overlap. There will continue to be the need for open surgery. There's going to be a continuation of the need to develop minimally invasive approaches going forward. So I think these things will overlap, they'll be iterative, but looking forward to the next phase, this issue of how to use AI, digital health, sensors, biologic therapies, and genomics to provide precision care and to actually take the individual patient data for the patient we're treating and then have that help us come up with an algorithm. That is coming. I think it's coming soon. And so it just makes me, I know I've recommended this book before to others, but I just wanted to say, you know, I'd like to be optimistic about the future, but everyone is telling me the world is going to hell. So I look to this, The Rational Optimist by Matt Ridley, and he's really a guy that he's a UK-based economist. He really looks at innovation. and thinks about how does that affect us. So he says today of Americans officially designated as poor, 99% have electricity, running water, flush toilets, and a refrigerator, 95% have a television, 71% a car, 70% air conditioned. Cornelius Vanderbilt, the richest person in the world in the late 1800s, had none of these. And this is how innovation works. And we sort of almost forget where we were as we look ahead to where we're going, but you know innovation's going to play a big role in it. The imminent incorporation of ChatGPT and similar AI platforms into daily life is quite unsettling. Henry Kissinger told the World Economic Forum this past year that he thought humans were going to be sort of irrelevant within 5 years. I don't think it'll be quite like that, but you hear these pronouncements and projections. You don't know what quite to make of it. But I'm sure that artificial intelligence and machine learning, and especially when driven by these other issues, are going to make a huge impact. And eventually we will be able to make individual decisions about vascular care on a patient-based level. And these are two recommendations I had for you. One of these was a very recent recommendation that I just received, but these are two excellent books about just ideas from experts about how artificial intelligence will be used. You probably know that ChatGPT 4.0 passed the USMLE, all 3 steps in minutes without going to medical school. So clearly this is something that's going to continue to learn, even as we get to a point in our lives where we've learned enough that we begin to forget things. And so this brings this prospect of, you know, again, where are we at this place in time in history? What if you practiced 50 years ago? Sounds like a long time ago, but these were the popular TV shows, Y50, MASH, Mission Impossible. This was the most famous doctor in the country, Marcus Welby, MD. The Best Picture Oscar that year was for The Sting with Newman and Redford. And this was an operating room circa 1973. And this is an era in which no matter how good your vascular skills would have been, they would not have been well used. Heart care and ICUs were not yet sophisticated. Swan-Ganz was just introduced. Aortic surgery and lower extremity bypass were actively being developed. No CT, ultrasound, digital imaging, cut film only, no outpatient anything, translumbar aortography, no hydrophilic coating, sheaths, stents, etc. Fogarty balloon had recently been commercialized and the first coronary angioplasty had not yet taken place. And this is the kitchen table of Andreas Grunsig, where he was working on the iliac angioplasty balloon that would be used for the first iliac angioplasty a year later. And in fact, if you had been just as skilled then as you are now, your skills would not have been used. Think about that for a moment. So as we are at a specific place in time in history, our time is a fortunate one. We've gotten to care for patients in the manner that we do with the tools that we have, with the colleagues and the high level of interest that others have surrounded us with. We also realize how special it is, and it leads to even greater appreciation. And you know, what's so interesting about vascular care, we get firsthand knowledge on a regular basis about how temporary the nature of human life is. And yet somehow we imagine, at least I do on a personal level, that it will never affect me. And we know that can't really be true. So what's my framework for remaining passionate about vascular care and about life in general? I bring it to 3 basic things: faith, family, and friends. So on a personal level, you have to have your belief system, and this allows you, it pushes you to be present and to practice gratitude. You have your family, which is really taking care of your family is your most important role that you're fulfilling while here on earth. And friends, if you surround yourself with people of goodwill, your life will be so much better. And these things really extend to the professional. On the issue of faith, you have to have a little bit of faith at least that things will work out. You have to be able to assess change rather than be fearful of it because you know it's coming. And you can't really be perfectly dismissive, although some ideas won't be good ideas. You'll determine that because you will have analyzed them, not just rejected them out of hand. What about family? Well, how do you balance work and normal life? Well, first thing is to take good care of your health. And what about friends? Well, if you work with people that you respect and you treat them that way, they will become your friends. So what about this work-life balance? I think true work-life balance is a myth. It's something that it's likely that something's out of balance all the time, And here's just a diagram from this book I really like called The One Thing by Gary Keller. But he's just kind of making the point that, you know, if you do work and life in the middle, your life will be just like that. But actually, the true magic happens at the extremes. That work often requires periods of high-intensity focus, and you have to be really deliberate about how you spend your time and be fully present in what you're doing at that time so you don't waste it. But your family needs a lot more frequent touches than that. And people are complicated, but life doesn't have to be. And you don't need to be afraid of new ideas, and realize that happiness is a choice. And my general rule of thumb is that rather than regret the past or fear the future, try to focus on the good in the present. So I mentioned to you my appreciation for the VIVA organization, really for my whole field in general. I'm so fortunate. I want to just say my wife is a Princeton, Johns Hopkins, UCSF trained doctor that spends almost all of her time helping other people with their lives. And she's been just really an inspiration to me and to others through all this time. And my kids, Colin, Beecher, Brenna, and Keeley, really, you think you're here to teach your kids? No, they're here to teach you. And I've learned really important lessons in life from all my kids. And then, of course, as they grow and they create their own families and they start to develop their own stories, it's a little like that third developmental phase of vascular, in the sense that you have less control, but the possibilities are amazing. The opportunity for change and growth is huge. And then lastly, I would like to have, this is the latest member of the family, I would like to have this joy every day. I would like to approach the day-to-day work with this kind of appreciation for life. She doesn't know what's ahead, but gosh darn, that's not stopping her. So in conclusion, the ability to do meaningful work, help those in need, develop your skills, push yourself forward toward lifelong learning, and have an influence over how the work is done are all key facets of a rewarding career and one of the pillars of a fulfilling life. This is the possibility that you have with a career in caring for vascular patients. So I would say it's a gift. So thank you very much for your attention, and thank you so much for, I mean, like I said, I'm not sure I even belong here, but I appreciate all the indulgence that you've given me over these past few minutes to go over these ideas with you. Thanks.